Hello and welcome to Mental Health. It's a Trap. We're your hosts, Susan and Stephen, mother and son, unraveling the complexities of the mental health traps people fall in. Join us on this podcast journey as we demystify the mental health labyrinth, explore common issues, and provide you with tools to navigate this sometimes extremely daunting terrain. You can expect engaging conversations, personal stories, and probably also have a laugh or two. Access to mental health care should not be what causes you additional stress. We invite you to follow along, and together we can embrace the darkness. All right, welcome back. We have another awesome guest, and the last guest and the one after this are kind of some connections from my mom in the therapy world. And so we are grateful today to have Julie with us. Welcome, Julie.
Hey, thanks for having me.
Of course. And Julie has a lot of experience. She's a clinical social worker. There's a lot. So I'm going to let her kind of dive in to introduce herself, and then we'll learn more about what she does and provide awesome information and tips at the end.
Sounds good. Well, thanks for having me. So where to start? I think I best describe myself as a social working mom, which are three things to balance, right? Those are all three different things, right? Trying to maintain a social life and work and be a mom all at the same time and somehow fit it all in. So I have two little ones at home. So that's the most important thing. Everything I do, I have to try to be a role model for them. But I've been in the human services field for over 25 years. I started working with people with disabilities before I could get my working papers. And that's the field I know I was supposed to be in. I always kind of joke around that, well, I would like to say it's a joke, but it's very honest and real that I had one other job outside the disability field. I waitressed for one day. I dropped a tray of empty glasses on the patrons. I walked out, and then I went right back to being a direct support provider because I have no coordination, but I also am not supposed to work in any other field. So if you'd like me to help cater or anything, please don't. That's a bad idea. But yeah, so I've worked doing everything from direct support and educate in working in school settings and at Perkins School for the Blind and residential settings. And then I went into social work out of necessity because there was a point in my life, one year in particular, that my loved ones with disabilities, so some of my very best friends and my family members have disabilities, and we went through some pretty tough stuff all in one year. I could access therapy and they couldn't, and that was just crap. So instead of going into special ed, I went into social work instead because that wasn't going to fly. So I'm still working on it. So that's kind of what got me to this place, and I think hanging with you guys today.
Great. And so we know that you've developed a model. We'll call it a model. Is it a model? Would we call it a model?
It is, yeah.
Okay. So, and I was fortunate to attend a preview of this model with Julie, and I really like the model, and I kind of work in that model without even knowing it in more ways than not. And Julie and I worked in community mental health together for many years now. And Julie also created a program there. If you wanted to share a little bit about that program, because that program has gone across the state into other community mental health centers, right?
It has. Well, it's right. It's the hope that one day we'll have an expectation of care, which will just be a quality and service delivery. And I really would love to see that in every state, right? Kind of the idea of mental health with universal design, that mental health is just made for all people and not for people based on one diagnosis or another. So that's the hope. But I did develop a program that was intended, it came very organically. And it was developed to bridge the gaps between the developmental service system and the mental health system. So my brain always works like a Venn diagram. So, those overlapping circles. And because I worked in developmental services forever before coming to mental health, when I came to mental health, I thought I was working in a completely new field. I walked in, I did the whole new clinician thing where I wrote down everything everybody else said and said, I'll never write a note like that. And I have no idea what I'm doing. And why are these people wanting to talk to me? And within a couple of weeks, I realized a lot of the things that we were doing were the same as developmental services, but we were calling them different names. And we were being really redundant. And so immediately I thought, okay, well, I got in this field because I wanted my loved ones with disabilities to have access to mental health care, but I don't want them to have to repeat their story, and they don't want to have to repeat their story. So what do we do? And that really is how the model came to be. So I brought together the Venn diagram of the circles of the mental health and the DD fields and looked at the overlap and said, where can we aim to create one team, one set of meetings, one message? No matter what agency you work at, let's all be at the same table and understand that the hats that each person at the table wears. And then when we come up with a game plan, I know exactly what each person's going to do with that plan. And that coordination of care is really important, but also kind of making sure that we were modeling person-centered approaches. And in that idea of bringing things together, so frequently we weren't seeing that our clients were at the head of their teams. And that doesn't sit well with me either. So making sure that when we were creating our program, that we were modeling for everybody, what does it mean to put the client at the head of the table and ask them the questions, and what is it that you want, and ask them what's going well instead of what do we need to fix. So that's the model that where you and I met. And then from that, I developed, or even before that, really, even before that, but developed something called Bookends Therapy. So it's not just for therapists. So I should have come up with a better name, to be honest, but so Bookends Therapy is a model of training and a model of approach with individuals, and they don't have to have disabilities. It could be substance use disorders. It could be anybody, but how to take a whole person or person-centered, team-supported approach to care. So when you think about bookends, bookends only they hold up the book. They're really not the most important part. You're there for what's in the middle, right? You're there for the story. You're there for, but that book has to stay stable. You don't want it to tip over. So bookends is about bringing supports in at the beginning and ends of session with consent, and putting the individual in the lead of their care, in the lead of their team, to let their supports know what they need, help with the check-in at the beginning, what's been going well, what are some of the things that we need to chat about today, kick them out, still have our autonomy, and at the end, make sure that the individuals are in the lead of doing the teaching of the skills to make sure we're building rapport, and get rid of the idea of the clinician says, Julie says that you need to, because that doesn't go over very well, right? So far so good.
And so you said something about the name, and maybe I should have thought about the name, because it's not necessarily just therapy. So what other professions would benefit from looking at this model and implementing this model into their practices?
Yeah, I'm really glad you asked. As Bookends has been used by teams for over 10 years now. And I just got it moving forward with a certification mark. So it's up at the US Patent and Trademark Office to actually be allowing me to already be able to certify people in the model. So we have different certifications. And currently it is a clinical certification. So for clinicians, disability services professionals, so people who might be direct support providers, residential providers, service coordinators, or case managers, anybody who may work in some type of disability support field, but not necessarily in a clinical capacity. We have mental health professional certifications. So people that might be case managers or something that is not necessarily a clinician, but think about case managers. It could even be the administrative staff of a mental health practice. Shouldn't we all be on the same page? So I think anybody that could possibly be in a mental health field, and to be in a mental health field, you don't have to work at a mental health center. We all kind of work in mental health, right? We also have an education professionals certification, so bringing this to schools. One of the people that we had in one of our first certification trainings was a social work student who used to be a teacher. And that was wonderful. She said this would be a game changer in IEP meetings. What would it be like to actually ask the students what they want their goals to be versus
Oh, and I've sat in some of those meetings with clients over the years, and it's basically there's no student input in that whatsoever,
so what's the point?
right?
I mean, why are we there? Is this planning or is it a directive?
Right, exactly.
And if we continue with that trajectory, which is there and it's common, I have done special ed advocacy for a long time, and without the input, we're making assumptions as to what's best for people. And assumptions are really, really dangerous.
Yes. And interestingly, on one of our prior podcasts, Stephen, you remember the one where we talked about, advocacy, like being able to advocate with your primary care provider, your clinician, like whoever the professional is that you're working with. And more often than not, I've heard from a lot of people, I'm not being heard. I don't feel like they're listening to me. They're automatically assuming it's this when I tell them what I'm experiencing, whether it's symptoms and how it's really harmful to patients and clients if we're not listening to them. And we talked about, you as how did you word that, Stephen? The professionals, like we have the education. I forgot how you worded it. Want to jump in?
Well, I mean, ultimately, it's the power dynamics, right, that we're seeing in our country right now of I have to listen to this person who has this degree or these degrees or their doctorate or their MD. And I'm trying to think if I said this at the last podcast, but about Meme, like she loves her doctor. His word is God. She will do what he says. She trusts him. And there's nothing wrong with that. Like if you have a provider that you really trust, I mean, I think that's huge. And then it makes us as the professionals, gives us more responsibility to make sure that we're doing right by our clients and patients and helping them to be curious, because I think that's when we have the power of influence to help them with their own agency. Kind of like what we're talking about here is with kids and with anyone that is going to get a service, wants help, but we don't want to be told what to do, versus like, how can we help them find it within themselves and be a part of their journey and not pull them along.
I have so many things that are like right here, and I'm like all of them, right? Because you just hit on so many important things, right? So the first one that I thought of, let me try to remember these things because you are so fantastic. So the first thing was when I first started doing special ed, when I got certified in special ed advocacy, I am working with families. It wasn't about teaching them about the laws in the special education laws. It was about teaching them, and I literally would use these words and it would freak people out. And maybe it made me sound snarky, but like what you see is what you get, right? I had to teach the parents that yes, the laws are important, but first you need to realize that you don't have to put your hand up for the teacher anymore. So where it's so ingrained in us that, okay, there's a professional. They must know what they're talking about. I'm going to listen to them. I'm going to do what they tell me. But when you go into something like an IEP meeting and there needs to be, maybe you don't agree with what's on the paper. Maybe you do need a different type of plan. Maybe you do need other resources or accommodations. You have to be comfortable speaking up, but it is it's a cultural shift. You're literally retraining yourself to relearn what we knew culturally of you respect the teacher, right? You respect the professionals. And I had to literally go like, you put your hand down. You're like, it's okay. And then it's no different in medical services. So there is like you mentioned the medical model. And that's what I saw when I came to mental health. And I think it opened my eyes to it and it really freaked me out. And it still does. That you have the social model of disability, which is the idea that like disability is a social construct. Medical model says, well, we have to fix that. Why? Is this your problem? Like, I'm doing all right. The world has to help work with me, right? Like some universal design. But when you said, sorry, when you said the medical model, that is exactly, I realized when I was sitting with teams that there was an assumption, right? That decisions were more often made for people with disabilities. So we were having interactive annual meetings and treatment planning and all that with other folks. But when it came down to people with disabilities, their teams came in with the draft, not from mental health per se, but from their developmental services agencies. They came in with a draft of what goals they thought they should work on. That's kind of the medical model, right? Here, this is what you need to fix versus the person-centered model of let's sit down and let's figure out not only what I want to work on, but what my strengths are to help me get there. What am I already doing well? Like what's versus the fix and the negative and where is the buy-in going to be? Because inevitably that's going to be the positive outcome. But again, it goes back to a major, major cultural shift.
And that's really true. You know, when I grew up and went to school, it was like you don't question the teachers. And you know what? Teachers they were not always good teachers. Just as there's not good social workers or good doctors. And you know, I'm not saying that people are bad. It's just I felt like that was such a disservice to me when I was in school. And if a teacher was wrong, why couldn't I say that they were wrong? If they could say that I was wrong, if I did something that was out of line, right? And I've raised my kids to say, you can challenge any adult in your life as long as you're respectful about it.
Mhm.
Because we know, and we're adults now, we know we're not always right. And we have to own that. And that's not what we're taught. That's not how our culture is. It's I'm the boss. So we can I'm the parent, I'm the doctor, I'm the clinician. It doesn't matter that we are those things. What matters is that we're listening to the person in front of us and helping them navigate what they want to do, right? It's so easy to say to people, don't do this, drink more of that, don't drink, don't smoke. You need to exercise. You know, you need to get out of the house more. You need to push through your anxiety and then send them off on their way. And so what do you do with that?
And isn't that exactly the opposite of what we're supposed to do, right? Like if you're in school, I mean, I teach now in a social work program and you know, it's when our clients come in and they say fix it. So we're told, well, let me help you come up with the tools and figure out how you're going to use them. Like do with, not. And then we fall right into this pattern of we see so many folks when we're setting goals for people. or we're communicating their needs, but we're not doing it collaboratively with them. We're not doing with, not for. We're making assumptions. We're doing it on their behalf. And I was seeing so much of that. I've seen it my whole career. And I've seen it with my family and my friends, and some of my, my friends have, my family and my friends have not only physical and developmental disabilities, some of them have had chronic medical conditions, um and they've had a lot of stuff going on. And there were very few times, I think about my best friend who has since passed away, and she and her two siblings had mitochondrial disease. So they've all, the three of them have since passed. But when I think about us growing up, I met them when I was 6. The oldest was 6 too. And as we were growing up, I watched people ask her mom questions and ask me questions. I remember as a kid at recess looking at I think this was my first like big advocacy moment, or maybe it was my first aha moment. But I remember looking at another kid that we were at recess with, and he came up and he started talking to me about her. And I was like, she's smarter than you. She's bilingual, right? You can just turn around and talk to her. I think that's where Bookends actually started. So when I say it started a long time ago. I'm pretty sure it was at recess yelling at that kid. But it happens all the time. Or they did it when I would bring my cousin, like I was of the generation you get dropped at the mall and you get picked up at the same place like 8 hours later. And they would drop my cousin and I off, and my cousin uses a wheelchair and she's blind and she has cerebral palsy, and we'd be in the mall and she couldn't fit in half of the stores. And because her arms were outstretched. And so she'd say, I want to talk to a manager. I'd go get a manager, and I'd be a little kid and they'd come talk to me. And I'd say, not me, her. And they would look real confused. And then she would open her mouth and really confuse them. But I think that's really where it all comes from, is these assumptions and how dangerous assumptions are. And then from the social work perspective, when we document, if we don't ask, I come from the belief, especially where I've implemented this in Bookends, if we don't ask people what the most important thing we talked about today was, if we don't ask them to reflect, there's liability, because our documentation is then a complete assumption. We don't know their takeaways. We assume. But how do we actually know? And that's really the premise of Bookends, is asking and then allowing them to communicate that, and identifying discrepancies. So if there are discrepancies, helping and reframing and giving them that opportunity. But if we don't do that, I'm going to argue that it may actually go against our code of ethics. I know that's like real extreme, but if you want to talk about liability, write notes without talking to clients about it. I don't know. That's just me.
No, there's there's a guy by the name of Dr. David Burns, and he created Team CBT. So it's the CBT, cognitive behavioral therapy model, and it's testing, empathy, assessments, and methods. And he wanted a structure that was backed by evidence from the client. So in the beginning and the end of every session, there was a like 5 or 10 question survey. Like, how are you feeling? Where's your anxiety? Do you have depression? SI, relationship issues? And then I think it had 2 positive questions. And at the end, they redid it. And if it wasn't a perfect score, which that's going to be hard to do unless, I think from bias, sometimes people lie so that they don't make us feel bad. But if they didn't get a perfect score, then it gives the therapist an opportunity to say, oh, it looks like I missed 2 or 3 points. Could you help me figure out, what you would like change, or if there was something that I said that you didn't like? So it helps to open the door to figure out next steps, whether it's for the next session or even in that moment. So you can track every session on if you're effective or not.
That's pretty powerful. I think people are afraid to ask. Like, do people actually want the feedback? I mean, I think about home care providers and I think about residential settings and all of these programs where we just go about the routine, especially for people with disabilities. Well, we took care of them. They were safe today. They were healthy. They didn't get hurt. Nobody, we call them behaviors. I hate that word, behaviors, right? It's mental health. But all of these things, people are afraid to ask. They're afraid to step outside of the norm, but we're going to stay stagnant if we don't ask and we just keep a status quo. The status quo is kind of dangerous too.
Right. And it kind of reminds me when I do supervision towards licensure, and some clinicians have sat in supervision and said, I'm just really feeling stuck with this client.
Mhm.
And I go, let me tell you this, if you're feeling stuck with that client, imagine how that client is feeling. Right? And it opens up an opportunity to talk about the stuckness, like what's not working, what is working, how do we move forward, right? Instead of saying, I can't work with this client anymore, they're not making any progress, and we blame the client for everything, right? When in essence, it could be something that we're doing. And again, I think people are afraid to have constructive feedback on what's working and what's not working. And on the client perspective, like, I don't like conflict. I don't want to say anything. What are they going to think about me? And so we get into those spaces. And I encourage patients to do that all the time. I'm like, hey, if I say something out of line, if I say something you didn't understand, if I'm talking too fast, like, just let me know. I can modify what I need to do. And Julie's heard some interesting therapy sessions I used to have back in the day.
I miss just hearing the laughter that would come from your office. And that's the real stuff, right? Like I've over the last 12, 13 years, I've developed a model for like a program from scratch. And then there's the team, and the team's gotten big. And the prerequisite to be on my team is please don't smile and nod. Like, just don't BS people. If you're going to be here, people want a human. They want a real person. And so if you're looking to be the smile and not therapist, and we're going to go sit and you wish you eventually someday have the office with a comfy couch, I'm not sure this is the right fit for you, because chances are you're going to be sitting on the floor at some point during this therapy session, or like somebody's therapy session, right? Like my therapy sessions, so if they need to sit on the floor, I've had people doing push-ups on the walls. We've been walking around, we play, we will literally do just about anything as long as it's, safe and ethical. But like, let's meet people where they're at. And I remember having somebody not long ago, she came in my office and she just literally popped down on the floor. Her team looked at me, and so I just plopped down on the floor next to her. We just hang. You want to hang down here? Looks way more comfortable for me too. Normalizing choice and using humor. I missed that laugh. Oh my goodness. You know exactly what laugh I'm talking about. And hysterical. Like, you can feel it.
Yeah, we had some good times. And
That's how
again, right. And I think just having humor and being able to laugh releases such big endorphins in the body that it really allows people to not always think about, I'm going to go to therapy and just talk about all the stuck stuff and depression or trauma or whatever it is that they're coming in with. And again, listening to what their needs are. Right? Do you want to do plants? We'll do plants. Sure, I don't care. You want to play a board game? Play a board game, because sometimes even in those moments when you're doing those things, they tend to be retaining better because it's less stressed of face-to-face contact, sitting in chairs across from one another, those types of things. And I mean, there'd be days I'd go lay out in the grass for the client. Well, let's lay on the grass. Who cares, right? And it's also helpful in identifying like kind of what maybe some of the challenges are for the client by trying different things, right? And making phone calls with them to see how they advocate for themselves with a provider like at the PCP office or whatever. And I think those are parts of the things of teaching, modeling, and helping them to be able to do that independently to the best of their ability, right? I've had clients or patients say, I'm really anxious about talking to my PCP about that. Okay, so what do you think will help you in talking to your PCP about it? Do you need me to come with you as a support? Can you go on your own and we can make a list of the concerns? Can we send your message to your provider on the portal to get them ready for that appointment so they know what you're coming in with, right? And so it's just coming up with some strategies and solutions so they can have their needs met.
It is. And if you can, it goes such a long way. If you can model dignity and respect for people in a therapy session and you treat them like a human versus a patient, you suddenly have changed the concept that, wow, maybe other people could treat them that way too. Or maybe other people could see them that way. And I've had people that I think about one person in particular, but you know, we have people that it takes everything they have just to walk in the building. And sometimes they're really late. And they're late because it took everything they had just to get there. And then maybe they get there on time, but they sit outside because it's still really daunting. And they were there, but they were. So what am I going to do? Am I say, sorry, you were here, but you were late? Or am I going to knock on the window and wave and just, wait it, there are different things. Am I going to go downstairs and maybe we're just going to sit out and have that chat through the window? It's a nice day. Roll down your window. That's cool. Let me know when you're ready. If you want to stay out here, that's awesome. If you want to go inside, do you want me to give you space? Do you want to, I just wanted to let you know it's stuffy inside and it's, whatever. Like we have flexibility, but I don't want to rush you. I want to respect. And then all of a sudden, us doing all of that, seeing the person, right? So that whole person approach, seeing the whole person, not labeling them, treating them with dignity and respect, giving them autonomy still. All of a sudden, those are the people that all of a sudden now are coming in early for their sessions because this is the one place they feel seen and they feel safe. And they're coming and hanging out with the receptionist. That's awesome. But if we automatically count them out, which happens, they didn't show up to their appointment, they missed however many, we're done. So I think it goes back to that whole person approach of there's not a single person in this world that just has one thing going on. And then doing that and modeling that for the primary care doctor too. And that's why like with Bookends, we had a primary care doctor at the last training, and this could be used really well in the medical setting. It actually could probably help with some liability too, because we need to be asking people medical questions one-on-one, because when we ask with their support systems there, not only are we not likely to, is there going to be a possible discrepancy, but a lot of times we just make assumptions. Oh, well, you would never do that, right? Because we don't want to make anybody uncomfortable. And the client's sitting there going, yeah, I do. I snuck out of the house last night. I was hiding. Yeah. And the mother's like, no. And we don't want to make mama uncomfortable. So why would we? So we ask assumptive questions. So it's like all of these things that if we take a whole person, client-centered, team-supported approach, it's just about modeling. It's modeling and a culture shift.
Did you have any other, there was a few things that Stephen mentioned that kind of jogged your memory of, know if there was any other things that came up?
Well, I think the medical model. So I'm teaching right now. So all of this is right in my head, and I was grading today. So I will just steal shamelessly from all of them. But The lack of assessments for people with disabilities. Again, because the assumption, well, it's your disability, right? Or the diagnostic overshadowing that happens. Well, we assume. So those symptoms, they have to be from your disability. They must be from your autism, or it looks like a psychotic disorder. So we're going to put you on an antipsychotic. But maybe it is a symptom of anxiety and autism. Right? So we have so much room for education. So much room. Most people don't actually even know that the diagnostic manual on intellectual disability exists. And it's an accompaniment to the DSM. I call it my social work Bible. But people don't know that resources are there. But what we find is that if we continue to live we're just seeing that if we continue to live in these silos, we're making assumptions that people with disabilities, they don't do drugs. Well, we know people with disabilities are 3 to 4 or 4 to 5 times more likely to have severe persistent mental illness. I heard a statistic once that upwards of 90% of people with disabilities will experience some type of trauma in their lifetime, which tells me that we are obligated to assess for mental health needs. If that's the case, we have to be assessing for mental health needs. We can't assume it's a disability. We need to be asking those questions. But then on the other end of that, we know that people that have trauma are more likely to use substances. So all of those substance statistics that exist for people with disabilities and saying, oh no, it's much lower. Crap, you're just not looking into it deep enough. Because people with disabilities are more likely to be socially, financially, sexually exploited. And they may not know is it okay to, well, sure, I'll try this. I'll do this. And that's why we wind up so we're talking about juvenile justice system. We're talking about the justice system. We're talking about substance use disorders. You can't tell me that people with disabilities don't have mental health needs and that we don't have an obligation to at least do an assessment.
Yes.
So, but our job is to model. If we can do nothing else, we can be squeaky wheels. But at the end of the day, our job is to model. And I think about my kids, and we were in the airport last week. We went to Florida, and we were walking in the Manchester airport, and there was a couple who were both using wheelchairs, and they were pushing their luggage while they were manually pushing their wheelchairs. And we were parking our car in the garage. And so my girl saw them go in. And when we went to go in the doors, my daughters said, I can't remember which one it was, but they were both very upset. They're 5 and 8. And they got to the door in the garage and they said, there's no button. How did that couple get in the door? And I was like mama moment, right? Because, I didn't have to tell them. I didn't have to, honestly, I was in like crazy travel mama land. And the first thing they thought is, how did that couple get in? And then they said, my oldest said, and I'm going to write a letter. That's not okay. And I was like, and it goes just back to that modeling is you don't realize the power of who's watching. And it could be little kids, it could be other people. Somebody else might just see how you have a conversation with somebody without treating them differently. You just don't know who's watching, but I think that just at the basis of Bookends, putting putting our clients in the driver's seat, if we can model that for other people, it's a good start.
Well, I joke with clients sometimes. I go, listen, you are the driver. I'm the passenger. Just want to let you know I do have a steering wheel and a brake if needed.
Yeah, that is exactly it. I feel like you should have a sticker on the side of your car just to like prove the point. Like one of those driver's ed, like Susan's driver's ed sticker. And you know that like I'm about 2 seconds from cricketing one for you. Like I'll get it in the mail in about 3 days.
I'll put it on the car.
I know you will. That's the thing, but that's what people need. They need the humor. They need all of that. So it's pretty cool to see the outcomes.
And how often do you do trainings?
I have a training coming up I have a certification training coming up in April. So April 3rd and April 10th, it's going to be 2 hours each day. So certifications include 4 hours of training. And then in order to be certified, so that's the training component. And then in order to get certified, participants attend 3 hours of a community of practice. So again, the nothing about us without us idea, right? Let's put it into practice. Let's get it going. And then let's come back together as a community of practitioners to learn from each other. What's going well? Where am I struggling? Hey, what were your ideas? What population did you work with? So we've had several people get certified. And what we're finding is that even after they attend their first 3 community of practice meetings, so it's one a month for 3 months, and then you receive your certification, most of them are coming back to build a community. So I'm really excited that there's a Bookends community now and a community of professionals who can lean on each other. And so we offer a community of practice that's open to everybody that's certified or working on certification. So we have those twice a month. And it's just, I learned something, and it's great to be able to sit back and just watch, and you'll see people that work in schools, in mental health settings. I had folks that worked in early intervention, people that have backgrounds as educators, all different backgrounds coming together to say, hey, that worked really well. I'm steal shamelessly. Why not? That's the community part. So I do have that April training coming up. And then I do trainings on a request basis too. So I'm hoping that I'll be scheduling more so people can sign up. But at any time, anybody can request a info session with me or just a one-on-one. And then I also do trainings for businesses. So doing consultation. My passion beyond disability is work culture. So we can have the best clinicians in the world, but if we don't have a place that they enjoy coming to, and if they don't have a good fit as a team, our clients are going to know. And so when the clients walk in the door to my department, they know everybody really enjoys each other and that it's genuine and everybody really enjoys them too. And they kind of get a community the minute they walk in the door. It's kind of like the Norman Cheers moment, right? Like everybody's woohooing. And but workplace culture is essential, I think, is essential to positive outcomes for clients too. So
I agree, because that impacts it impacts client care. And just clients walking into those cultures are impacted, right? And if it's an unhealthy work culture, then really it's such a disservice to the people we serve.
they know the difference. They can feel it on you. They know if you're having a rough day, but they also know when somebody has your back. And they know that we have the motto, nobody flies solo. So if somebody might be your primary assigned staff member, but you get the whole team. And that's really, but the team gets the whole team too. So if somebody's feeling down, if they're feeling stuck, I'm not saying it's kumbaya all the time. We all have rough days. But at the end of the day, if we can help each other get through it and nobody's feeling alone, that's a really, really important thing. So some of the trainings that I help organizations with are around workplace culture. Recently I did a training on helping to maintain your own well-being during times of uncertainty, or whatever that might mean in this world right now, and it's so self-care is a little bit, it's used a lot, but how do we just kind of take care of ourselves and each other? So again, going back to that workplace culture. piece, modeling the environment you want, not the environment you have.
Are your trainings in person or through video?
Both, both. I love a good in-person training. I do, but I do video. I've done virtual trainings in different states. I've done actual conferences, and I've done virtual conferences in different states. I've traveled to different, both. So either or, we'll make it work. I do my best to bring the energy virtually, which, in person is a little, running around, but I promise to do the same thing virtually. My trainings are always very interactive, and I do have ways of making sure that that can happen virtually too. So I just kind of caution people if they think that they're going to come and sit there and, just kind of listen, and that's great. That's great. But I really stand by that any good training leaves you with the opportunity to practice a skill set. So you shouldn't say, here's what I learned, but here's what I did. So that's really my commitment through my training and my consultations, is to really not lecture, but make them interactive.
Those are brutal. Lecture trainings are brutal. I'm not gonna lie. I walk away and go, I sat through that, and again, there's no retention because there's no interaction in it. It's just listening. People are reading from their PowerPoint slides. I'm like, you could have emailed me the presentation. I could have read it all by myself. So yeah, I get that.
Yeah.
Role playing, I don't like. Just saying.
No. The role playing piece, it makes people uncomfortable. And so, but let's put a scenario out there, and so come up with a scenario, that was challenging for you, or come up with a scenario that you felt most successful in. And now let's practice that skill set. Maybe you felt really successful. I wonder how this could have enhanced it. Or maybe there's something that there was a challenge with. Let's see if that could have helped. But we don't always have to be deficit based and say, oh, what are we here to fix? I can't fix anything. I can't support changing anything if I don't know what's going well.
Mm-hmm.
And we do the same thing in therapy. I don't care how you're doing. I want to know what's been going well since I last met you. Then we'll get to how you're doing. Maybe.
Yeah. And it's true because we tend to focus on, I generally will say to people, how have things been since we last met? I don't put a yay or a nay on it.
Yeah.
How have things been going since we last met? And some patients have said, it's been a pretty good couple weeks. And, so we talk about that. And if there were challenges, we'll talk about that. And, and then we talk about, okay, so if these things come up, like, how do you manage it? And how do you, because people come in sometimes and they go, you're here to fix me. I'm like, then you're in the wrong office. Like,
Can you
I
fix
don't
me
need
first?
anybody. Right, exactly. And sometimes they would say, so where's your couch? That we don't have couches. There's no couch. Couches keep you stagnant and comfortable. And then you stay stuck in the unhealthy, comfortable place. No couches. Nope.
I tell people at intake, I tell my team to tell people at intake, my job is for you to do so well that you put me out of a job. You're not here. This isn't meant to be forever. We're going to get that skill set. It's okay. It's okay for you to say you don't need this anymore. It's okay for you to say you're good for now, and then us talk about what it might be like to revisit. But the successful part isn't that we've developed a relationship where, I have a family member who's had the same therapist for like 30 something years. That's not a therapist. That's a friend that you're paying to hang out with. It's like something shady. So do so well you put us out of a job.
And it's interesting that you say that. So when I worked in community mental health, I felt like we kept people sick, and I recall saying, I didn't come into the field to keep people sick. I came into the field to help people do better in their lives. And, and to me, if someone is in it for the long term to that degree, something's not working. And what is it that's not working? Right. And I have that conversation with my patients. So the environment that I work in now, I met with some people like 3 or 4 appointments and off they went. And, and having conversations with other patients saying, my job is to not work with you.
Yeah.
And we all need support in our lives from time to time. So when you need support, you come back in, then off you go. If you need a tune up, you can come back. And I just like make it in joking ways, though, and firm kind of boundaries, just because who wants to be in therapy for the rest of their life?
And if that's what they say they're looking for, we have to help them realize what it is they're really looking for. When there was a period where I developed and ran a program in a inpatient rehab setting. So a neuro rehab. So more of like, if you fell and broke your hip, or if you had a stroke, or maybe routine surgery, but more of that type of rehab. And I would say it made me the clinician I am. It made me a better clinician because I had to go in assuming my sessions were 40 minutes. I had to go in assuming that I might meet that person once, probably no more than 3 times. So I had to assume that this was my only shot to get something done with them and leave them with something in 40 minutes. So relationship and rapport, assessment, diagnosis, skills, and resource and referral in 40 minutes. And let me tell you, it's possible. And it made me a better clinician because it wasn't, oh, well, we'll talk about that next week. No, Emmanuel said so Emmanuel is one of my friends and mentors. And he said to me yesterday, and I think if I was a tattoo person, I'd probably get it, but like I hate needles, so no. But it's tomorrow. He said, tomorrow is today. That's not, so if I keep saying, okay, we'll talk about that next time, why? What is that pause? What is that pause point? And then next time we're going to say, okay, and then the next time we'll talk about if there's something that we feel we need to leave somebody with, really, really focusing on making sure that we don't procrastinate too much or make the assumption that we have it next time, because we don't always. And maybe if we actually start talking about it, we won't need so many next times.
Exactly.
Yeah.
Well, this episode has been filled with lots of nuggets. And I think it speaks to anyone who's listening, whether they're a therapist, clinician, doctor, human person dealing with mental health disabilities, whatever you want to call it, because if we all lump it together, right? When we think about labels, like labels can be both good and bad because it helps us identify and connect with each other, but then it's also like boxes us, which kind of sucks when you box yourself because then there's no room to grow if you're like, this is who I am, this is my routine, whether it's a quote unquote negative routine where you're just in the slump and you stay in it, or it's a positive routine, but there's no growth either, right? So kind of expanding, and we've talked about this before, of growing and being open to doing different things, right? So firing your therapist if they're not a good fit for you. If you're with them for a long time, like, are you codependent because they feel like a friend and they feel safe and you want to stay with them, which is kind of like what you were talking about, is what's the underlying, why do they keep going back for 30 years, which boggles my mind, but it happens. It's the system too that we're trapped in, because when you think about a lot of mental health places, the turnover rate is so high. How are we actually teaching therapists and clinicians the skills they need versus getting someone new, and then maybe they're so busy that they can't train, and so they just keep getting clinicians who are doing the same thing over and over and over again, and they're not helping them grow and learn skills to help clients do the work they need to do, right? So it's kind of, my favorite word, it's nuanced. There's a big gray area of like things that we don't know. So we need to be in supervision and consult with each other. But I think that's a missing part, right? So like with a lot of clinicians, like are there groups, and like I'm in a couple of groups and they're like huge. So it's like, it's nice for that support, but what does a localized support look like? So I mean, it sounds like Bookends is kind of like one of those things where you create a community where you support each other versus like these, I don't know if it's like 10,000 in the social worker support resource group online. And so you can post and you'll get a lot of information, but they're all in different places, and right, the feedback could look different. So having a way to connect with like a core group sounds like it would be more beneficial than just getting people's opinions, so to speak.
Yeah, and having the opportunity to connect with people who have been trained in a similar model, but are like-minded in their approach. So we've all been trained in the social work code of ethics. We all likely go to some type of accredited program, but it doesn't mean that we all have the same values. And even in Bookends, people don't have to have the exact same values and the same skill set. But I think when people come together and they use the same language, so whole person, person-centered, client-driven, team-supported, modeling, gentle challenging, right? Like what are our keywords that aren't nuances, right? But they're keywords that we say, this is really foundational to my practice. We talk about our non-negotiables. So what are the non-negotiable things? How do you want to create your expectation of care and not the exception? So to do something, say, oh, well, that really worked. Like I'll do that once and never again. Why? Shouldn't we all be creating our expectation of care? And what do we want that to be? So Bookends really is, it can be used in any treatment modality, DBT, CBT. I mean, real first episode psychosis, anything. But it's about how we work with people and how we put the people at the forefront. And we make sure that we're modeling for teams. So teams understand that we're actually modeling a cultural change for teams. And if we can impact that cultural shift, so that's where that community really comes together, is hopefully developing something that I hope will catch on. But what we see is even before we had the certifications, the people that were doing it, they were starting to use the terminology, and then people at other agencies and other scopes of practice, they were looking forward to it. Well, could we do Bookends today? It would be really helpful if we could come in and we could all, yep, absolutely. And so again, it really just lends itself to the change in culture, and we need a change in culture.
Oh, yes.
For sure.
Is there a place that people can find you if they're interested in learning more about Bookends?
Yeah, absolutely. So I have my my organization is called Connections All the Ways. So Connections ALL ways .com. And then if you also go to bookendsTherapy.com, it will take you to that section of the bookend section of the Connections website. And then on most social media, I'm under Connections Always.
Well, it was a pleasure having you on the show.
It was so nice to be here. Thank you so much.
And if anyone has any questions specific for Julie or for Bookends, I encourage you to go check out her websites, or if you have a comment, you can leave it here on the podcast. And then, as we always say, we'll always love to have Julie and our guests back so that we can provide more education, information, tips, and tricks. And I hope everyone else takes care.